Hello, Jennifer Dufresne again, registered dietitian, here to talk to you about tube feeding. So you've been given the option of tube feeding for your loved one. My last video was about aspiration pneumonia. So I'm assuming your loved one or parent has been given the option of having a tube placed either directly into the nose, which goes into the stomach, or surgically, which goes directly into the stomach. And the feeding formula goes either in the nose through the tube or directly into the stomach. What are the benefits? What are the risks? Why tube feeding? Why can't they eat? So they're probably told that they have aspiration pneumonia, which my other video explains what that is. And if they are aspirating the food into their lung and the fluid into their lung, now the only safe way that they're given to eat, if they're going to be aggressive, if the patient can withstand having a tube placed, is to get a tube placed in order for the food and fluids to go in. However, tube feeding is not necessarily a backup plan for eating for many reasons. If somebody, whether it be you or me or our parents or somebody that we love dearly or a patient that we're taking care of, is towards the end of their life. And when I say end of life, I'm talking about within the last year, within the last year of their life, most likely. It could be hours, it could be months, it could be weeks, it could just be a year left. But if you're really looking at the end of life and you're dealing with a frail, elderly patient, many times a tube feeding is not the best option because there are risks. And tube feeding doesn't necessarily prevent aspiration. So I want to make sure I give a really good representation of what tube feeding is, because it's not a cure-all. It's not a backup plan for eating, like I said, but there's a time and a place for tube feeding. There are many people on tube feeding every day. And your parent may have even been on tube feeding in the past, and now they're contemplating getting it again. It doesn't necessarily prevent aspiration, which a lot of people don't know, and maybe they're not told. They should be told, because patients can just aspirate on their own saliva. They don't even have to be fed anything. Maybe they haven't been eating for days, either by tube or by mouth, and they've aspirated just on the spit or saliva in their mouth and throat. So you can aspirate on pretty much anything. Tube feeding sometimes works against the body's natural course. So if the body is naturally already on the roll towards the end, it's starting to shut down, it's not functioning, it's declining, tube feeding is not a valid option at that point, and we can discuss that a little bit further as well. But the main reason is because that can contribute to significant amounts of discomfort towards the end of life. So we'll go over what discomforts those are, and I wrote them down because I want to make sure I don't miss them. Some of the discomforts associated with tube feeding, just so you have a fair picture of what we're dealing with here. Someone who is on a tube feeding and is not as healthy as you and I, and they're not able to get around as easy. Maybe they're bedridden. They're gonna obviously urinate more than they would than if they were eating and drinking on their own, because their body may tell them they don't need as much as would necessarily go into the tube. So having more frequent, either getting up to go to the bathroom or have more frequent changes. Sometimes if those functions aren't working so well, there may be some fluid overload, which would be swelling in the abdomen, or it could be swelling on the skin if they already have something called edema or bloating. The body also may have some GI discomfort, whether it be frequent bowel movements or whether it be constipation. It's hard to predict exactly how each person is going to react to that. If the feeding is what feeding is, for those of you who aren't aware, is the tube feeding is just going to be however much is needed for the patient is going to go into the tube, whether it's through the nose or in the stomach, however much is needed. And usually it's done either continuously, like throughout the day for 20 hours, if they're bedridden, or it may be bolus, which is given 1 can at a time, or sometimes 2 cans at a time. For example, like during meal times, breakfast, lunch, and dinner, maybe they're getting 1 or 2 cans in the morning. 1 or 2 cans at lunch, 1 or 2 cans in the evening, and depending on how much volume they can digest comfortably, they may end up having another feeding later because they can't get a lot at one time. So those are the 2 different ways, but either way, it goes into that tube. So if the patient is full or they're not feeling very well, it's still coming in because it's being pushed in with the tube. That's one of the things that I don't like about tube feeding at the end of life, because the body doesn't have an opportunity to naturally react. Like you'll see with your loved one as they age, they will start to slow down with their feeding. They won't want to eat as much. They will be full quicker. They need less. Their metabolism slows down. Their digestion slows down. They're not moving around as much. They're not burning as many calories. So it's very natural that their intake is going to decrease. Their needs have decreased significantly. So they don't need as much. When the tube feeding goes in, they don't have the opportunity to react until it's too late. And that's when they'll get a bellyache or bloating or vomiting or diarrhea. So at the end, tube feeding is not necessarily a good option because of that. That's not the body's natural course of tube feeding. And let me see, I had some other notes here on this one. Oh, there we go. Also, if the tube is in the stomach or even in the going through the nose, it can get dislodged, which is very uncomfortable. It's supposed to be lodged in the stomach if it's being fed in the stomach. Some patients are fed in the duodenum and some patients fed in the jejunum. But if it is in the stomach, which is the most common place, it could get dislodged and there could be bleeding associated with that and pain. And then some other not so comfortable things could happen. Also, if the tube feeding is not the appropriate amount, it could just, let's say it's a trickle feed, or they're trying to slow down the feeding because the patient's not tolerating it very well. Let's say it's like half of what somebody needs. And then we'll talk about that in another video too, because I think that is almost cruel to feed somebody half, because that means they're getting almost enough, but not enough. And that keeps the digestive process going. The juice is flowing, whereas it should either shut down naturally or they should eat as much as their body wants them to have. When you're feeding them which is a force feeding, it's pushed into the tube, and you're not giving them what they need. You're giving them, it's like a tease for the body. And I'll go over that in another video, talking about tube feeding versus not tube feeding, and what actually can happen at the end of life if you keep that feeding going versus just allowing the body to naturally take its course and not eat if it doesn't want to eat. And there's many signs you'll see, and we'll definitely talk about that. But tube feeding is an option for those patients who are still strong enough to go through the surgery and their digestion is still working and they may not be so close to the end of life. And that's usually because they're aspiration pneumonia, or aspirating dysphagia, they're not able to safely swallow their food. So tube feeding is a viable option for that in those cases. But again, if they're end of life, there are many complications that occur, and it doesn't, the body is not allowed to react to not wanting food when the food is pushed in them. And worst case scenario, and it has happened many times, families who have want to very desperately, because of love, it's all usually with very good intentions. That's why I've made these videos, because I don't think any loved one has ever made decisions, at least not in my career, to hurt their loved one. That's why I think knowledge is power. So if families can have the knowledge and education, the experience from a registered dietitian, a validated source of information about nutrition and my 20 plus years in healthcare, 15 plus in home health and hospice, then I want to impart my knowledge on you so you can make a better decision in your loved one's life. But worst case scenario, I hate to go over this, but it's important to know this is a very, very viable possibility. Patient dies, tube feeding still running. That can be very messy. The body does not have a chance to turn it off. The body is not regulating the signals with the tube feeding. It's a machine pushing food and fluid in a body. If the patient is allowed to eat and drink naturally, the body, even if they have dementia, will tell you when they don't want it. There'll be signs that occur that slow down the digestion and slow down the process of intake. So if your patient and loved one's still strong and they have aspiration pneumonia and they're not able to eat a diet safely, the speech therapist and the physician have said not even puree thickened liquids. They're going to aspirate. They need tube feeding even after therapy. And they're strong, go for it. If they're towards the end of life and they're not looking at having treatment and curative measures, it's probably best that they go through the natural course of passing, which is natural, normal for everybody. The appetite's going to decline eventually, even those that do choose tube feeding and that are healthy right now, they're eventually not going to be able to tolerate the tube feeding, and natural things will occur: bloating, vomiting, diarrhea, discomfort. But if someone's already at the end stage of life, the last few months, you don't want to put them through that, I wouldn't say. So hopefully this has enlightened you a little bit. And I wish I could talk to you and get any questions that you have, but I do have other videos and I hope they'll be helpful for you.